This conference will now be recorded.
Okay, so welcome all of you to the class. So today I'll be doing this as a new talk has come. So I have to do it. So this is, there are two parts of this class. So this is part one where non-epithelial ovarian cancers are there. Okay. Next class will be coming, next part of the class will be soon coming. Okay, so according to this new talk, you guys are likely to get question from here. Uh, Part 3 people can get Viva station, and part 2 people may be getting questions because this is very important. Therefore, I wanted to update, so I'm taking this class again. Okay, so according to this talk, so non-epithelial ovarian cancer, there are rare forms of cancer. Okay, so according to this talk, I'll be speaking according to this talk only. According to this talk, they are divided into three parts. Okay, malignant ovarian germ cell tumors, 6 called stromal cell tumor, and ovarian sarcoma. So I'll be speaking in all three categories separately. Okay. Now we already know that it will be important to know a little bit, basic, because that will help in finding out from where which tumor is coming and from where which marker is coming. Okay. So oocytes are the totipotent cell. That means they can grow in any tissue within embryo. Therefore, granulosa cell tumor, even as abnormal growth, they may develop according to embryological lines. Sometimes question do also comes, and also it helps in finding out what type of tumor marker we have to do. If it is trophoblast, then it will be syncytoblast and cytotrophoblast. Usually, if you that non-gestational choriocarcinoma is there, this arises from there. From yolk sacs, these are endodermal cells, and from embryo epiblast. Not too much, nothing important from here. The important part of the, it comes from this part of the slide. Now, germ cell tumor, this differentiation and few percentages are important because it is directly asked in exam. Germ cell tumor, they are divided into two parts. Okay, one is undifferentiated, another is differentiated. Undifferentiated is only one, that is dysgerminoma, and this percentage is 45. This percentage is 45. So just remember that dysgerminoma arises from the undifferentiated cells, and it is really important because you will get a lot of questions from dysgerminoma. Now coming to second variety is a differentiated. Why it is differentiated? Because different cell lines are there. Okay, you can see here cell lines. So if the tumor is arising from a whole blastocyst, then it will be embryonal carcinoma. If it is arising from embryo, this is important. Okay, then it will be teratoma, and it is 20%. Now it again is divided into two parts. Why these two parts are important? If it is mature teratoma, that we call as a dermoid cyst, that we know so much questions comes from dermoid cyst, and we see them all time in the clinics also. So this will be the dermoid cyst, that is mature teratoma. But if it is immature, then it is called as either immature teratoma, or it is also called as a malignant teratoma. So this is important to know because answering your questions become very easy. So embryo teratoma 20% divided into mature and immature. Immature is, we already know, and immature is malignant teratoma. From yolk sac, there is only one tumor arises, that is yolk sac tumor, and that occurs in 20% of the cases. From trophoblast, as I already said, it has to be choriocarcinoma, but non-gestational choriocarcinoma, it is very less. It is less than 1% only. Too much numbers are like not required. Just you have to remember what is the most common, that is dysgerminoma, 45%. Next, you have to remember yolk sac is also 20%, and teratomas are also 20%. Okay, this much is enough. Apart from this, you see this table, flow chart, and in this flow chart, all are malignant tumors. Only this mature teratoma is the benign. Okay, it is the benign. So this is important to understand from the basic and from the cell lines. Okay. Now, like presentation is different from whatever the ovarian we see. They usually present more acutely and at an early stage. That is a good thing about it. If patient comes to you early, then uh, usually patient will present at an early stage of malignancy, so the treatment and prognosis would be better. Okay, now what is the, you will find question from this line. Usually they are very rapidly enlarging abdominal or pelvic masses. Patient will come with acute lower abdomen pain, and sometimes the tumor rupture also. Okay, this very they rupture also. There could be hemorrhage, there could be torsion. So you will find a question in your exam that identify a tumor that has got tendency to presenting acutely, suspicion of tumor rupture, and answer will come to GCT. The urinary symptoms and rectal symptoms, it occurs like epithelial cancer. Menstrual irregularities may be there because they are hormone secreting. Sometimes they present with the beta hCG production, so the urine pregnancy test may be positive. Sometimes the patient will come to you, and the patient will come to you with the hyperthyroidism symptom, because excessive of the beta hCG is there, and we already know that it cross react with the TSH receptor. Okay, so question may come from this part also, that patient is coming with hyperthyroidism, and they will give you some mass, then answer will come to the GCT, that is a ovarian GCT. So take home and learning point, it presents as earlier stage, more acute presentation, tendency to rupture, to hemorrhage, or to go for torsion. Okay, now usually the like epithelial cancer, usually both ovaries are involved, but here they are usually unilateral. Only dysgerminoma, 10 to 20% of dysgerminoma are bilateral. Okay, dysgerminoma are bilateral, 10 to 20%. This number may be important. This is from strategy. Now how they will present: distended abdomen, pelvic mass ascites. If it the advanced disease, there could be pleural effusion, palpable lymph nodes, and hepatosplenomegaly. Okay, nothing more there. Very important part is to remember this, that this germinoma, in 10 to 20% of the cases, they could be bilateral. Now again, you will get a lot of questions from this tumor marker. This table is from that TOG only. Okay, so it is in this format, it becomes very difficult to remember. So I try to put it in this manner, so that it becomes easy to remember, because this you have to learn, because so you get direct question from here. Okay, this is like for this germinoma, the marks that I have put in the red, these are the a specific kind of marker. They will always present, but other markers may be present. So red ones are markers, because it was too confusing in strategy in this talk, and the new talk that has again also come, that will be doing next class, different. They have put different markers. So I tried to put and compile up in this slide, so that the things become easy. So for this germinoma, you think LDH is quite specific, but HCG may be raised. Okay, you have to remember this because this germinoma, a lot of question comes. For embryonal carcinoma, alpha fetoprotein, LDH, and beta HCG. Okay, immature teratoma, these are alpha fetoprotein, LDH, and DHEA. Immature teratoma, we know it's like uh, arising from embryoma, and it is like having it, all cell line can develop. So alpha fetoprotein, LDH, and DHEA. So these are the tumor markers. Choriocarcinoma, we remember HCG because we know it's a pregnancy, but in some LDH is also written in the table. Okay, but it will be less, but main marker is HCG only. Yolk sac tumor, so many number of question, and you have both are the tumor markers, LDH and alpha fetoprotein. So I just you, if you guys can remember the red ones, you'll be able to answer the question. These are the germ cell tumor markers. And for sex cord cell, these are easy. For thecoma, it is inhibin. For granulosa cell tumor, it is inhibin AMH, that we already know because we do it for ovarian reserve also, and testosterone. This testosterone is written in the talk table. Okay, Sartoli cell, it will be alpha fetoprotein, it will be inhibin and testosterone, or DHEA and andro okay. So these are the tumor marker. The most common that you have to remember from this, I try to compile it from all sources, and the most important that you have to remember is this red ones, because you are going to get questions from this red one. If you see this chart of another talk, then they have done a very nice job, because they have put tumor marker, which tumor marker rises in which tumor, so that also helpful. So alpha feto, according to it, alpha fetoprotein, if we think as a tumor marker, so it could be alpha fetoprotein. We already know that it will be in the immature teratoma. It will be in Sadoli leading sac tumor, yolk sac tumor, and also it will be in embryonal carcinoma. So this way also important, you can remember. HCG, we already know that this germinoma and embryonal carcinoma. LDH is again in two, dysgerminoma and immature teratoma. CA125, we already know it is epithelial cell tumor marker. CEA, again, if it is a epithelial cell, but mucinous variant. Estradiol, it will be estrogen, it will always be in granulosa cell, and testosterone will be in sartoleydic cells. So you remember this, or you remember this, but you have to remember, because both of the talks are new, so very highly likely to get questions. Now usually these are the young girls, so fertility is an issue for them. So before planning for any treatment, so what are the tests that talk says, apart from the general preoperative test? So it would be TVS. We already know TVS can only be done if the woman is sexually active. Second, other is the CT scan of thorax, abdomen, and pelvis, chest X-ray, and blood test. In blood test, tumor markers are done. Relevant tumor marker, we already know, because they help in further, a baseline tumor marker has to be done. Then rest tumor marker follow up for the treatment by measuring this tumor marker can be done. Another will be like if a PET, or that is a PET scan, that is done in the selected cases. Why? If inadequate staging has been done, for example, incidental diagnosis of GCT has been done, or patient restage adjuvant chemotherapy is given, and patient is going for restaging, so then PET scan is required. It is not for all. Another question that comes, this question also comes, like if it is patient is going for another surgery, or if there had been incomplete surgery, what is the investigation of choice? Your answer will be PET scan. I have seen this question many times. Another question that also comes is like what is the dye that is used in a PET scan? That is 2-FDG, that is a 2-fluorodeoxyglucose. This is another question that comes, so you have to remember. Apart from this, granulosa cell tumor secretes estrogen, that we already know. So as a part of treatment, before this patient go for any kind of surgery, endometrial curating is also done. So you will get a question, like these are the following tumors, and patient as a mark of a preoperative worker, curettage has been done. So you have to identify a tumor, and you already know it is GCT. Now, this is some basic. Now I'll be speaking about individual tumor. What are the? I'll be doing only with the question specific. Okay. So germ cell tumor. So these are the germ cell tumor, and this is from the WHO to 2014. So these are the germ cell tumors classification, whatever they have given. Now coming to dysgerminoma, this you have to remember because a lot of question, from dysgerminoma comes. Dysgerminoma is the commonest. We saw in that table also 45% was the dysgerminoma. Okay, so this is from the another book that wrote 40%, but that flow chart is from strategy that shows it says 45%. So this is the commonest malignant germ cell tumor. It is bilateral. We read just, and it arises from undifferentiated cell that we also learned. And if it associated with a dysgenetic gonad. Now what does it mean? For example, like you guys might have seen question of this androgen sensitivity syndrome. Okay, and sometime gonadal dysgenesis is there, and we counsel this patient. Why we counsel? Because for the gonad, and we say that gonadectomy is required. But why we are saying? Because there could be possibility it may turn up into a cancer. And what is the type of that cancer? That will be dysgerminoma. So this also can come as a question. Okay, they present in young age. They may coexist with a pregnancy also, and dysgerminoma may coexist with other tumors also, like dysgerminoma or choriocarcinoma can be together. Dysgerminoma and like endodermal sinus tumor can be together. So it can be, dysgerminoma can be with pregnancy, with choriocarcinoma, or with endodermal sinus tumor. And the tumor marker we have read in the table. So what are the tumor markers? These are LDH and HCG only. So LDH and HCG, these are the tumor marker for dysgerminoma. Now you will find question, this is important for part 2 people. Like this is the histology picture, no need to remember. Just what you have to remember is that usually this monotonous pattern of the cells are present in size. Like you can see these are similar looking, almost similar looking. But what clue in the question? There is a lymphocyte and plasma cell infiltration here. So you will get a question where they will say there had been a tumor, and in the histology there had been a lymphocytes. Your answer will come as a dysgerminoma. Okay. Now this is the update from that talk. Okay, the new talk. So what the talk says, usually what the talk says, that in fertility sparing surgery can be done in 1A, 1B, and 1C. And what is this fertility staging surgery? That I'll be just speaking in upcoming slides. So patient is young, and they are desirous of fertility. So you can't take everything away like we do in the staging laparotomy. You have to give them space so that they can complete their family. So fertility sparing surgery is done. In that, whole surgical staging is done, whole part, and one side, like one side ovary and tubes are removed. So one side of ovary, tube, and uterus is left so that they can complete their family. So again, for in this talk, for every tumor staging and what is the requirement of the surgery at that particular staging they have done. So I have also put in the same way. But basically you have to remember is that in stage 1, usually fertility sparing surgery can be offered, and more than stage 1, that is from stage 2 onwards, fertility sparing surgery usually cannot be done. Okay. Now apart from this germ cells tumor, they have got very high, like intensity to come back. So usually the patient who had these kind of tumor, they are under acute surveillance. So acute surveillance is done for them. Okay. So now in if the dysgerminoma is a diagnosis, in stage 1A, B, and C, fertility sparing surgery can be done. And more than that, there will be full staging chemotherapy, full staging debulking surgery with adjuvant chemotherapy. So in stage 1, A, B, C, fertility sparing surgery along with surveillance is required. Remember this much. But in to 4, full staging surgery, debulking surgery plus adjuvant chemo is required. Okay, so this is according to the talk, and also the strategy says the same. So dysgerminoma, these are usually uh, they are chemosensitive tumors. Okay, they are chemosensitive tumor. The only one tumor that is too much radiosensitive sensitive is again dysgerminoma. You will find this also as a question, but the problem is there, if the though it is very sensitive to radiation, but if the radiation is given, you already know what will happen. There will be fibrosis, so there will be loss of fertility. So if the patient is a young patient, having this germinoma, we will not give them radiation as an option because of the fertility issue, though it's a radiosensitive tumor. So you will find question from here, which tumor is radiosensitive? Answer is dysgerminoma. Now coming to second variety, that is the immature teratoma or malignant teratoma. We already saw in the first flow chart. The origin is embryo. If it is immature, then it is malignant. It is a second common germ cell tumor, and these are never bilateral. Usually these are unilateral, or the unilateral tumors only, and they present in the young woman. Okay, less than 20 years of age. So, and yeah, it is a malignant, so 30% of death from this ovarian cancer. Okay, you see, so bad this is, because this is malignant teratoma. This slide, this screenshot is not from strategy. It is from Novak oncology book. Okay, just to show you, this number I have put this. Now, you will get question from this part. You will find a lot of questions. All books they do have, and in their pathology, in immature teratoma pathology, usually immature neural tube like structures are there. Now you can see this. I have put this picture only so that you guys will have an visual memory, because when we answer a question during the exam, sometime if we just remember it from memory, sometime we forget, but visual impression of a picture makes impact. So I put it a picture. So now you can see these are the neural tissue, and undifferentiated it isn't. Prognosis will depend upon quantity of immature neural tissue that is there. Okay, just see this, just remember this picture. That's all is required for this exam. Again, immature teratoma, what the talk says as a treatment part. So treatment part, what they say, fertility sparing can be done for 1A, B, and C. Okay, 1A, B, and C. But chemo, if you think of chemo, then in 1A, grade 2 and 3, 1B and C, adjuvant chemo has to be given, because it is very, the chances of it is immature, malignant potential is high. So adjuvant chemo is given, and rest all other more than this stage 1. So this is all advanced stages. It will be full staging, debulking surgery, along with chemotherapy, along with adjuvant chemotherapy. Now this thing has to be remembered in this patients. Usually these are young patient, and usually the whole lesion is present in one ovary only. So unilateral oophorectomy and surgical staging can be done. But if it is a post-menopausal woman, then complete surgery is done. And veg biopsy, or biopsy of another ovary is unnecessary. I will show you that strategy thing also. So the infertility preserving surgery, if they are doing for any woman, they're never taking any, they're just doing assessment of the another ovary. They're not taking any biopsy from it. Okay, so this is all about the treatment of immature teratoma. It is highly malignant. Now third is the endodermal sinus tumor. We already know that it arises from yolk sac. Young age, third most common malignant tumor. It is almost unilateral, associated with this germinoma that we read in this germinoma also. What is important to learn that you will get in the exam, that in the pathology line of endodermal sinus tumor, usually uh, like like there will be presence of this Schiller-Duval body or SD body. And what is this? So this is a Schiller-Duval body. With there is a central vessel. Okay, there is a central tuft of vessel is present, and this mantle of endoderm is present. So sometime I have seen one question one time in our COG course. They have given a question about the description. Therefore, I have put the description of this Schiller-Duval body here. So there is a presence of cystic space lined by there is a flat epithelium, and there is a tuft of vascular tissue inside. So this is a tuft of vascular tissue. This you have to remember. You get question from here. And apart from this, eosinophilic haline bodies are present in the tumor that contains alpha fetoprotein and other proteins. It is a highly malignant tumor. It spreads to adjacent structures rapidly. But the good thing is that in almost 100% of the tumor cases, it is unilateral. So no need to touch another ovary. In endodermal sinus tumor, now again, coming to the treatment options. So fertility sparing can be done in stage 1 and 2. And like if adequate surgery is not done, then only chemo is required. More than 1B, it is full staging. It is full staging or debulking. It for every tumor, remembering type of surgery becomes very difficult. But overall, if you see 1A, grade 1, 1A and grade 1, usually fertility sparing surgery and surveillance. And more than it will be fertility sparing surgery and surveillance and chemo. More than 2 or 2 to 4, it will be full staging and chemo. Okay, so this is the basic thing. So answer for EST treatment will be surgical exploration, unilateral oophorectomy, because in this it is unilateral. EST is the unilateral tumor. So why to remove another ovary? If the hysterectomy and oophorectomy is done, then the outcome will not change. Outcome will not change because it is 100% single ovary tumor. Now, this is the same thing I was trying to say, because I remember, though the talk says table wise, but it is very difficult to remember. So summary of surgical treatment: fertility sparing surgery usually done by the midline incision. And what is the infertility sparing? Unilateral salpingo-oophorectomy and surgical staging. Biopsy of contralateral ovary is not recommended. This impairs fertility. This is from the strategy. Okay, you have to know this. Apart from this, if advanced, if the patient comes and the disease is already advanced, then chemotherapy can be started as a primary treatment, that we call as a new adjuvant chemotherapy. And after the completion of few cycles of chemotherapy, then later on the surgery will be done to resect residual disease. So maybe you will get question from this line: disease is already very advanced, so answer will be give new urgent chemotherapy followed by surgery. Another important thing that you have to remember, even if this surgery has been done, tumor has been removed completely, but they have got very high probability of coming back or recurrence is there, and usually they called as a teratoma syndrome. So in that condition, if the recurrence is there, it has to be removed surgically, and after that chemo is given. Surgical removal followed by chemo. This is the this is a basic that you have to remember for surgical treatment. More than that, it is not required. Though in the tumor, it is in the talk they have given independently, so I put independently. But this as just a summary. Apart from this, again, a summary from talk. So they malignant germ cell tumor are 1.5% of ovarian cases cancer. This number is from talk, so you may get this as a question. 60 to 70 diagnosed at an early stage. This also you can get as a question. Usually treated by surgery and acute surveillance or adjuvant chemo. Very sensitive to chemo, and most patient these are young girls, therefore the fertility conserving surgery is done. Full surgical staging is the gold standard in the management. If young patient, please go for fertility sparing surgery. For young for family, if the family is complete, or old patient not desirous of family, consideration for radical surgery. Radical surgery means full staging laparotomy. Lymphadenectomy is not required in these tumors. You may get question from this also. This all is a sum up of TOG only. Continued same. So decision to treat germ cell tumor, it depends on the grade and stage. Usually stage 1 can be safely managed without adjuvant chemotherapy, and but acute surveillance can be done. I will talk you about the surveillance also. Women should be counseled to avoid pregnancy in first 2 years because the relapse rate is very high. This is a question that comes. Even this is important for part 3 people also. Most commonly, the regimen used is BEP and EP, but if it's high risk patient, that is POM based is a regimen. Too much detail is not required. This much is enough. So this is from the talk what they said. Adjuvant chemotherapy for non-epithelial ovarian cancer is the EP regimen, that is a etopside and cisplatin, or BEP, bleomycin, etopside and cisplatin. Usually 3 to 4 cycles are given. Now this you may get as a question, that because it is from the talk, that BEP is used in less than 40 years. Okay, if it is more than 40 years, old woman, so we give EP only, EP. So this part is there in the talk, so you should know this. What could be a complication? There could be hearing loss, ototoxicity, nephrotoxicity, pulmonary dysfunction, Raynaud's disease, and secondary malignancies. So two questions you will get from here. So which agent causes pulmonary fibrosis? Answer will be bleomycin. Bleomycin causes pulmonary fibrosis, therefore pulmonary dysfunction occurs. And also you will get this also as a question, which cancer can come after the chemotherapy? Answer will be AML. Answer will be AML. Okay. Now risk of gonadal dysfunction is there because chemo radio has been used. Therefore whenever this type of young patients are there and the treatment is going to start, always discussion about cryopreservation before chemotherapy should be done. And risk of POF, premature ovarian failure, after chemotherapy is 3%. Okay, this number may be important, this because this number you will get in the next class also when I'll be speaking about rest of the talks. So this number is important. What is the premature ovarian failure after chemo? Is only 3%. This is a sum up whatever given in the talk. Now this is the acute surveillance regime that has been given in the talk. Okay, though if you go to strategy, the regime is different. If you go to SIP of 2016, this surveillance is different. But if you guys get any question about the surveillance, in my opinion, answer will come from talk, because the talk is the most recently updated. So though it is very difficult to remember, but a few things you can see, like examination and tumor marker. If you see them together, in first year it is monthly, second year it is uh, 2 monthly, third year it is 3 monthly, fourth year is it is 4 monthly, and from fifth to 10th month, 10 years, it is 6 monthly. So it is according to the year, and same is the number of month. So you can remember this way, because question may come, because the talk is new. And what could be the pelvic scan? So you just can remember 246. That is a table of two, that will help you in remember. And chest x-ray is again a table of two, 2468. Okay, in which year? So in first year 2 monthly, second year 4 monthly, third year 3 monthly, 6 monthly, and fourth year 8 monthly. After that it is annually. After that it is annually. So this way you can remember it. I like try to simplify it that way only. So examination and tumor marker, they are monthly, 1 month monthly, second month 2 monthly, third month 3 monthly, 4 month 4 monthly, and fifth year onward 6 monthly. Pelvic ultrasound 246, chest x-ray 2468. This way you can remember. And CT scan abdomen and pelvis, 1 month after surgery, 3 months after surgery, and 12 months after surgery, and also whenever it is clinically indicated. So this way you can try to remember. So usually 75% of them will come back in first year. Okay, see, so high percentage they will come back. And what could be the sites of recurrence? Peritoneal cavity, retroperitoneal lymph node, and lungs. You may get question from these two parts. That's all about the germ cell tumor I had to say. Any one of you have got any question about that can ask me. Otherwise, I'll be moving toward the six cord stromal tumors. Any question till now? Okay. Okay, so yeah, it is too much to listen only. Okay, now the germ cell tumor is done. If you could, just remember that much, your all questions will be solved. Even part 3 Viva can be done with it. That much it is asked. In part 3 already Viva station has come from it in our COG course. Now coming to the second part of it, that is a sex cord stromal tumor. This is the classification that is again from the WHO. So I won't be reading this because that is not required. So the first tumor that I had to speak is about granulosa cell tumor. So granulosa cell tumor, we know it from our UG days also. They increase. There is secretion of estrogen. Because of that, there could be precocious puberty, there could be abnormal uterine bleeding or endometrial hyperplasia. They are usually granulosa cell stromal cell tumors. So thecoma, if it is thecoma, then inhibin will be a tumor marker. If it is granulosa cell, that I repeat, I spoke previously also, inhibin and AMH, these we are doing for the ovarian reserve also. These are the same thing. Okay, now what important, so what you have to remember is just in this that it is, they are estrogen secreting tumor, and you have to remember the tumor marker. So for thecoma it is inhibin, for granulosa cell it is inhibin and anti AMH or anti-Mullerian like hormone. Apart from this, like they have very high tendency to recur. So the long-term follow-up is required. They may recur within 5 to 30 years also. So after 30 years also it can come back. That only one line I have to speak from here. Now another line that is important that you have to learn, and you will get question from there. In the granulosa cell tumor, usually there is a present of a like granulosa cell, like they have got tendency they arrange themselves in a clusters or rosettes around a central cavity. If you see that there is a central cavity and cells are, they are making some sort of uh, clusters or something. So these are called as a call exner bodies. Call exner bodies. Okay. So this we know from the UG days also. In granulosa cell tumor, this much only you have to remember. So usually they can be present in the prepubertal girls only in 5% of the cases. In young girl, maybe they may come with a, precocious puberty or something. So prepubertal girl 5%, and they are bilateral only in 2% of the cases. I don't think so. The question can come from here because this is not from strategy uh, uh, or from talk. Just to know, just as for the general knowledge, I put it here. So this much is required for the granulosa cell tumor. Again, for the granulosa cell tumor, again, fertility sparing surgery can be done in stage 1A, uh, AC1, and A1C, grade 2 and 3. Okay, so fertility sparing surgery can be done, and from 1C onwards, 1C, okay, well, from 1C onward, it will be chemotherapy will be required. Rest all will be full staging or debulking surgery. Okay, so though like these in only 2% they are bilateral. So treatment of choice will be unilateral salpingophorectomy. But if the uterus is there left inside, then endometrial curating is done, because there could be a possibility of coexisting adenocarcinoma of the endometrium, because the estrogen is very high. Just for every tumor, remembering when the fertility sparing surgery can be done, so it will be very difficult. So usually, that I said before also, in stage 1 fertility sparing surgeries can be done. In stage 1A grade 1, usually no chemo is required. Rest, if inadequately staged, chemo would be required. And more than stage 1, it is full complete staging and debulking surgery followed by adjuvant chemotherapy. Okay, so just remember that basic also, because too much details about each tumor staging, they are not asking questions. Basic information will go. Now coming to Leydig cell tumor, they are androgenic. We already know that. So patient, you will get this kind of symptoms that patient is presenting with a defeminization symptoms, loss of hip fat, breast atrophy, hirsutism, irregular menstruation, hoarse voice, and male baldness pattern. Okay, so this will be the presentation, because excess of male hormone or the testosterone is there. These are the tumor markers. So alpha fetoprotein inhibin, testosterone, DHEA, and androstenedione. These are the tumor markers that you have to remember, because you will get question from here. Apart from this, I have seen a question from this also, because in RCOG course there was a question. They gave you rank. This Rinky crystal is the diagnostic of which tumor or present in which tumor. So answer will be Leydig cell tumor. So you have to remember this. You will find direct question from this line. Okay, so again, coming to treatment. So stage 1A, only fertility sparing surgery can be done. Rest all other more than 1A, they are doing full staging laparotomy, debulking, and adjuvant chemotherapy. Okay, and usually they also unilateral. So if the fertility sparing surgery is done, unilateral salpingo-oophorectomy will be enough. Unilateral salpingo-oophorectomy will be enough here. Okay, now again, this is the sum up from the top. What they say, like most of them, 90 to 60, 60 to 95, they are present in early stages. Treatment will be surgery followed by adjuvant chemo. And if the advanced tumors are diagnosed, So more extensive surgery, that is a debulking surgery, complete staging surgery, and adjuvant chemo is required. Women usually they are less chemosensitive. So this is difference from the germ cell tumor, that these are less chemosensitive. So role of surgery is more. Therefore, complete staging is recommended here. But yes, for the young patients, consideration for fertility sparing surgery can be done. Chemotherapy, again, it will be 3-4 cycles of either EP or BEP. But in this kind of tumor, 6 cells cord stromal tumor, consideration for carboplatin and paclitaxel can also be done, that we use for epithelial ovarian cancer. So this is different from the germ cell tumor here. Now this is a sex cord stromal tumor. What the talks says, this is a ESMO recommendation for follow-up. So in the follow visit, there will be history, examination, and tumor marker. So from third year, like every 6 monthly patients has to be seen. But pelvic scan, if the fertility surgery is done, then this will be accompanied by a pelvic scan every 6 months. So just it is easy, not difficult to remember. So from third year, indefinitely. Okay, so indefinitely now you can see 6 monthly, and if uterus is there, then TVS 6 monthly. So this is the follow-up for ovarian sex cord stromal tumors. Apart from this, in this talk, so now sex cord, so I have done with the germ cell tumor, sex cord cell tumor. This also has present, they have put in the talk. Therefore, I had to put it here because I had to complete the whole topic. So because you may get question from here, and I've highlighted the important lines from where you will be getting questions. So small cell carcinoma of ovary, that is hypercalcemic type. The few things you have to just remember, because if the question ever comes, it will come from here only. These are aggressive tumor, present as 24 years, very young age. Serum calcium levels are elevated. These are hypercalcemic, so serum calcium levels are elevated in 2/3 of the patient. In 2/3 of the patient, serum calcium level will be elevated. 50% are already spread. They are unilateral but already spread at the time of diagnosis. Chemosensitive but high risk of relapse. So cisplatin or etoposide are the chemotherapy of choice. Cisplatin and etoposide both are using, but most of the patient die within 2 years of diagnosis. So few things, because it is a small paragraph in the talk, but you can get questions. So just remember, these are aggressive tumors. Median age of presentation is 24 years. Serum calcium levels are high within two-third of the patient. They are unilateral, but the extra ovarian spread at the time of diagnosis in 50% of the patients. Very high risk of relapse. Treatment will be surgical staging followed by chemo or radiotherapy also. But the like 5-year survival is 10%, and most of the patient will die within 2 years of diagnosis. You may get any question from this. This much knowledge about this is enough. Again, they have added in this talk is the ovarian sarcoma. So few lines you have to know from here. That much will be able to enough, in your answering. So usually adenocarcinoma and craniosarcoma, these are mixed epithelial and mesenchymal tumors. Most important subtype you can get question from here, it is craniosarcoma. 80% of this occur in postmenopausal women. They occur in postmenopausal women, and age at the diagnosis is 63. So now we just saw that hypercalcemic type of small cell carcinoma, median age of presentation was 24, very young patient. But ovarian sarcoma, these are old women with a median age is 63. So apart from this, it is also very aggressive tumor. So these are so aggressive that they are managed in special, they have got in UK sarcoma units are there, so they are managed in specialist sarcoma units. Okay, so there could be treatment with the aggressive surgery, chemotherapy, and these are the chemotherapy what they have written, but I don't think so that much you can remember. Cisplatin, doxorubicin, ifosfamide. Okay, long prognosis is very poor and long-term survival is uncommon. Okay, little you have to remember it from here, because I'm not thinking that you guys will get any question from here. So craniocarcinoma is most common, most aggressive. 80% are menopausal women. Median age is 63. Treatment done in sarcoma units. Long-term survival is uncommon. Very poor prognosis. So that's all. That much is enough about the ovarian sarcoma. Now the what the talk says about HRT. So what they say that HRT in in hormone dependent tumors, usually HRT should be avoided, should not be given. But in case of germ cell tumor, uh, like uh, HRT is considered as a safe, or hormonal contraceptives are not contraindicated. Okay, so it depends on the uh, like uh, 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 their nature. If they are hormone independent, consideration for HRT can be given. Other, if they are hormone driven, then HRT is usually avoided. So that's all that I had to say today. It's a very small class. So anyone have got any question can ask me. Otherwise, I'll be asking you questions. Any question? Oh, it's a little boring topic. Okay, so answer me. Stay. I try to put make question from the talk, so it retains in the head. So relapse in stage 1A dysgerminoma is answer. Any guesswork will also work.
15%.
Okay, but it is 20%. So stage 1A dysgerminoma, it is 20%. Rest other non-dysgerminoma group, it will be 25 to 35%. You may get this. This may be in the question. Okay, so 24 years old woman has gone for fertility sparing surgery for germ cell tumor. She wants to plan for pregnancy. How long she should wait? I just told this. Any
Ma'am,
guesswork?
24 months. 24 months.
Yes, 24 months. Very good. So, recurrence of germ cell tumor are usually highest within first 2 years of treatment. So, women who are wishing for getting pregnant, usually we should ask them to avoid first 2 years post treatment. Okay, so this you may get in a question. Again, tumor marker to be repeated during first year of surveillance. Every 2 weeks, 4 weeks, 6 weeks, or every 2 weeks for 6 months, every 4 weeks for rest of 6 months, every 2 weeks for 8 months, followed by monthly for 6 months.
Every 2 weeks for 6 months and every 4 weeks
The
for
4 weeks
rest.
for rest of the.
Very good. So this is the for the first year. Second year we know 2 monthly, third year 3 monthly, fourth year 4 monthly, and after 5th month it is 6 monthly. That we know from that table. Now dysgerminoma arises from where? I just showed you the picture. Dysgerminoma is only one.
And ma'am, B.
Very undifferentiated. Only one germ cell tumor that is most common, 45% of the cases arises from undifferentiated origin is the dysgerminoma. Teratoma,
Embryological.
very good. From embryology, we have got teratoma. Teratoma could be mature. Teratoma could be immature. If it is mature, it is dermoid cyst. If it is immature, it is malignant. Okay, 17 years old girl diagnosed with a yolk sac tumor. What tumor protein you will do? Yolk sac.
Lactate dehydrogenase.
Yolk sac.
Lactate
नहीं alpha fetoprotein मैम.
Yes, protein. Alpha fetoprotein is an answer. LDH will be for this germinoma. Okay, so 19 years old girl for the surgery. Interpretive finding shows implants are there on fallopian tube and cytology. Okay, confirms so histology confirms granulosa cell tumor. CT exclude involvement of distance metastasis. What is the correct FIGO staging?
Ma'am, it is
2B.
2B.
Sure.
Peritoneal washings are positive. 1C cross. Yes, ma'am. Uterus and fallopian tube, it will be 2A, I suppose, ma'am.
2A.
Yes, 2A. Positive, they are implant outs, like these are 2A only. So what this says, implants on fallopian tube. 2A. See here, these are 2A is extension or implants on the uterus, on the fallopian tube, on the ovary. Okay, now come here. It is 2A. Now, for all other people who answered 2B, this will be extension to other pelvic intraperitoneal tissues. But UTO, that is uterus, tubes and ovary, UTO implants are 2A. Remember this. FIGO staging is same. So now I'll be speaking a little about staging also, though it will come in next class also. So stage 1, from where the question comes, that you have to know. So stage 1, only one ovary is involved. Capsule is intact, no spillage, nothing. 2B, both ovaries are involved, capsule intact, no spillage, nothing. Now very important to remember 1C, here divided into 3. 1C1, I was doing surgery, I had put rupture the capsule, there is a spill. It's my fault, surgical spill. So surgical spill is 1C1. You will get many question from this 1C1. The moment you see surgical spill, just put 1C1. Now I am not at fault. It was ruptured before, so it was 1C2. 1C2. But in peritoneal washings we found cell, then it will be 13C, sorry, 1C3. You will get question from here, most commonly from C1 and C2. This much you have to know about stage 1. Stage 2. Stage 2, again you have to remember that it is below the brim, below the belt area, below the brim. So A will be UTO, UTO extension, implants on UTO, uterus, tubes, ovary. If implants are present on UTO, it is A. But if it is spread and elsewhere in pelvis, but below the belt, below the brim, then it is 2B. Just remember this way. Staging is very difficult to remember, and you will get question and people do mistake. So you have to find out your ways of remembering it. So this is my way I used to remember. Okay, so this C1 stage 2 would be, in my opinion, it would be clear. Now come to stage 3. When it is above the belt, that means beyond the brim it has come, then we say this is a stage 3, outside the pelvis. Now again they are creating mess with the 3 stages. So stage 1, like stage 3A, just remember 3A is microscope. 3A is microscope. We can only see if we see it under microscope. So till here, the diagnosis will be under the microscope. You can't see with your bare eyes. Okay. So just remember this. 3A. 3A is microscope. So 3A1, they again created the mess divided into two parts. So retroperitoneal lymph node has come positive here. Therefore, it is 3B, stage 3rd. So in wave A1A, metastasis is there, but less than 1 centimeter. 3A1 part 2, it will be more than 1 centimeter under the microscope. Okay. Then 2B, it is about the lymph node only. Okay. So 3A1 about the lymph node only. Lymph node, we have got small size lymph node, So if you guys are doing a scan, then you will say always, okay, if the lymph node is more than 1 centimeter, then we take it as an enlarged lymph node. So with the lymph node, this 1 centimeter is, related. Remember, this is a one way of remembering. So 3A1 is lymph node stage, less than 1 centimeter, more than 1 centimeter. So divide them in 1 or 2. So one way of remembering. Now I'm doing surgery for staging laparotomy, and I am okay, sorry, again 3A2 will be, involvement other than the lymph node. So it will be like peritoneal involvement with or without positive lymph nodes. Okay, so 3A1 is lymph node stage. A2 is any spread above the brim with or without lymph node. So these are microscope. Now we come out of microscope. We can see them with the bare eyes. So if I'm doing surgery, and if I'm able to see a met in the abdomen, and if I'm able to see, then I can just feed. So once I'm able to see it, it is 3B, it is 3B or 3C. If I'm able to see them with my eyes, it is 3B or 3C. Now I just see them and I just find, okay, 2 centimeters or more than 2. If it is less than 2 centimeter, it is 3B. And if it is more than 2 centimeter, it is 3C. But yes, we are able to see with our eyes. But in 3C, so more than 2 will be 3C only. Here, liver and spleen can be involved, but only capsule. Outside is involvement, no parenchyma. You will get question from this part also. Only liver and capsule is involved, no parenchyma. I want to share my experience also. I was doing like hysterectomy for a patient with an ovarian mass. Though the CT scan was done and the CT scan shows tumor mark, CA125 was done, that was within normal limit. Therefore, we decided to do it because we are not onco people. So when I opened abdomen, I was able to see the omental, cake that was matted omentum, and I can tell you very well it was more than 2 centimeter. And that time when I saw it, and we say it's a 3rd stage, so that was 3C. And because it was more than 2 centimeter, we sent that to the histopathology and it came as 3C also. Then we referred that woman for chemotherapy. I'm just saying this because you have to remember it. So if you open abdomen, if you see a mental K less than 2 centimeter, you are dealing with 3B. More than 2 centimeter, you are dealing with 3C. These are the ways to remember, otherwise it becomes difficult. Now, so question will come from the 3C. They will say capsule is involved, but no parenchyma. Okay. So it is 3C. Now come to stage 4. Everyone knows what is stage 4. That is, it is beyond everything. It's huge spread. So lungs, if it is to the lungs, Pleural effusion with positive cytology, it is 4A. And if it is now substance of this thing, intra-abdominal organ is also involved. So parenchymal metastasis, here you will find a question that liver and spleen parenchyma is involved. Answer will become 4B. This is parenchymal metastasis. Apart from this, inguinal lymph node, just remember inguinal lymph nodes and lymph node outside of the abdominal cavity. Now, when we read squamous cell carcinoma, when we read inguinal lymph nodes, so they are involved at a very early stage because that is the outside cancer. But this is abdomen cancer. Okay, this is inside abdomen. If you are able to see lymph nodes inguinal, then you are at very high stage 4B. Why am I speaking about that? Because I have done myself mistake in this question, because I saw inguinal lymph node and I put it at, I don't know, very like early stage where I put, I don't remember, but I made mistake. Then I saw the staging again. Then I realized, okay, I was making mistake because I was messed up with the vulval squamous carcinoma. So this mistake I have done, I'm speaking about that, so you will not do it. So stage 4B is parenchyma plus inguinal lymph node. So this way, I try to explain it. So now the ovarian staging, hopefully it becomes easy for you. Okay, another question. 18 years old girl with right ovarian mass, stage 1 ovarian choriocarcinoma, what you will do? This I
Ma'am,
will.
it's three. It's three without any contralateral biopsy. We need not have to take that.
Yes, so it is 3 only. Very good. It is laparotomy, unilateral salpingorectomy, omental and peritoneal biopsies, and washings, because she's a young girl, early stage tumor. Girl with ovarian mass went to surgery. 1C, yolk sac tumor. In yolk sac tumor, what is the chemo? This is from strategy question. So this comes, what I just told.
Ma'am, two BEP.
BEP, yes. So if it, what I told you guys, if it is less than 40, it is BEP. If it is more than 40, then it is EP. And if it is an advanced disease, then it is POMBase. Okay. Yeah. So it is BEP. Now coming to 24 years old woman with a rapidly growing abdominal mass, abdominal pain. Radiology tumor marker suggests endodermal sinus tumor. Her case is discussed in MDT. What should be the best management? Someone should explain. Answer. So it is like endodermal sinus tumor, young girl. So what you will do? You will do surgical exploration. You will do USO, and it is 1C. This no, what they say, endodermal sinus tumor. Okay, so they will do a surgical exploration, unilateral oophorectomy with adjuvant or therapeutic combination chemotherapy. Now, why people are not speaking? See, radiotherapy cannot be answered, young girl. So, total hysterectomy
Ma'am,
cannot be answered.
third one again. Surgical exploration with unilateral salpingo-oophorectomy.
No, but you have to put them under, some surveillance also.
With,
Chemo,
yeah.
okay.
Yeah, ma'am, the fourth one.
What one will be the answer? See, radiotherapy cannot be the answer. Total abdominal hysterectomy cannot be the answer. Surgical exploration, USO cannot be the answer because you don't know what will come in histopathology. Maybe in histopathology, it comes as a high grade. So you have to do something for them. So answer will come to here. That complete surgical exploration, USO, with either adjuvant or therapeutic combination chemotherapy, because we will be able to know the type and grade of the tumor once the histopathology comes back, because right now we have got only radiological investigation. So answer will be 4. 3 will be incomplete answer. The surgical staging is again incomplete because you are doing more than that. Is it clear?
Yes, ma'am.
Yes, ma'am.
Okay, 17 years old girl recently seen with a quickly growing unilateral mass. During mass, team decide to incise the tumor capsule, 5 liters content with a suction prior to removal in order to avoid midline laparotomy. Some cysts spilled inside the cavity. After removing mass, it is GCT. So no evidence of malignancy on CT. What could be the stage?
1C1.
Yes,
1C1.
because we are at fault. We are surgeons. We have cut the capsule. So we are at fault. So 1C1. 42 years old woman diagnosed with non-epithelial cancer of left ovary. Her predictive preoperative workup, endometrial cell. They have done endometrial sampling. What is the type of tumor in this investigation?
Granulosa cell tumor.
Granulosa cell tumor.
Yes,
Granulosa cell.
yes, very good. 39 years old woman with a 5-month history of vague abdominal pain, anorexia, weight loss. Pelvic examination shows mass in right adnexa. What is initial investigation to diagnose malignancy? What is initial?
5.
What?
Transvaginal ultrasound. Transvaginal ultrasound.
Vaginal.
Yes,
TVS.
yes. 16 years old girl at the gynecology emergency with abdominal distension. CT showed left solid cystic mass. 120, CA125 is 100. Her tumor markers are normal. Fertility sparing surgery you have done. Now, excised tissue shows a grade 1 glial tissue. What could be the tumor?
Immature teratoma. B.
Yes, immature teratoma is the answer. And now you can see the, yeah. No, no, it is B. Who is saying C?
That's why immature teratoma, ma'am.
Yes, immature teratoma, and this is the neuroglial tissue picture. 19 years old girl with a bilateral solid ovarian mass. There is an increase in LDH, placental alkaline phosphatase, referred to Onco Center for further management. On staging, it is bilateral oophorectomy has been done. It shows lymphocytic infiltration. What could be the tumor?
C. Dysgerminoma.
Yes, C, dysgerminoma, and this is the lymphocytic infiltration. 20 years old woman present in the emergency with abdominal distension and pain. There is a palpable abdominal pelvic mass. Tumor marker alpha fetoprotein is 300. CA125 45. Refer to Onco Center. CT MRI done. And the histology shows a Schiller-Duval body.
D. Endodermal sinus tumor.
Endodermal sinus tumor, ma'am.
D.
Endodermal sinus tumor, and these are the picture of the uh, this Schiller-Duval body. 18 years old girl went to GP with the distension. MRI shows unilateral solid cystic mass, and MRI shows that it is confirmed to left ovary, right ovary looks normal. Her tumor markers are beta HCG, alpha fetoprotein are normal. She is referred to Onco Center. Laparotomy was done. Component of histology is glial tissue.
Immature teratoma, ma'am.
Yes, immature is not there, so answer will be malignant teratoma. And this is the glial tissue. 24-year-old woman present to the GP with abdominal pain. Clinical examination shows large pelvic mass. CT scan showed left side solid ovarian mass. Then with a rise in LDH enzyme, she undergoes fertility sparing surgery. Histology shows a vascular cell with clear cytoplasm and central nuclei separated by fibrous lymphocytes infiltrated with lymphocytes. What could be the tumor in her?
Dysgerminoma.
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 Yes. A 55 years old woman with a rapid access clinic for post-menopausal bleeding. Scan shows solid mass. THO BSO was done. And CA125 is 150 and inhibin level is 100 elevated. She undergoes laparotomy, omentectomy, and peritoneal biopsies, peritoneal washings around the abdomen. What could be the histopathology of ovarian mass?
B. Granulosa cell tumor.
Yes, because inhibin is raised. Inhibin is the marker for granulosa cell tumor. Again, it is a similar kind of question. So 20 years old woman for abdominal distension, her beta CA125 is 100, CEA alpha fetoprotein, beta SCG, LDH are normal. CT scan shows a mass with normal left ovary with normal right side of ovary. She undergoes staging laparotomy. Histology immature grade 2 neural tissue.
E, ma'am.
E. Immature teratoma.
Yes. Now it is so important to know this. So many questions everywhere it is coming. So 15 years old girl with right iliac fossa pain, multilocular cyst of 9 into 10 into 11, test release, beta HCG is high and lactate dehydrogenase level is high. What could be the type of ovarian neoplasm?
Embryonal carcinoma.
Yeah, what you're saying?
This, nahi, ma'am.
Embryonal carcinoma.
Dysgerminoma.
LDH is a marker for HCG and LDH are a marker for
Embryonic.
Dysgerminoma, ma'am.
yes.
Dysgerminoma.
Dysgerminoma. You can't say I'm speaking so long with this. You can't do mistake. LDH and and LDH and beta SCG are marker for dysgerminoma. Don't make it wrong. LDH and beta SCG marker for dysgerminoma.
D for LD.
Yeah, D for D. You can remember this way also, nice way. So a 6-year-old pediatric gynecology with precocious puberty, pubic hair growth, vaginal discharge, breast development, adnexal mass of 10 centimeter. What could be the diagnosis?
Juvenile granulosa cell tumor.
Yes, juvenile granulosa cell tumor. That's all for it. Any one of you have got any question can ask me. Any question, guys?
Ma'am,
Okay.
can we get the audio recording of this?
Yeah, I'll be putting that in the group, so you'll be able to get it from the link. And this is the like ovarian cancer class number 1. Class 2 will be coming, I think, on this Sunday. So I'll be covering in
Okay.
that class epithelial cancer, and there are 3 talks of ovarian and inherited cancer SIP. So it will be a bit longer class. It will be on Sunday, so you will find message in the group on Saturday. So if there
Okay,
are
ma'am.
no questions, then thanks for joining. Bye.
Thank you, ma'am.
Thank you, ma'am. Thank you.